So welcome and thank you for attending this Connect and Learn session organised by Boost, which is the North East and North Cumbria Learning and Improvement Community. My name is Ashley Eaton and I'm from Boost, and today we are joined by Dr. Kate Ward, who is a consultant clinical psychologist for Newcastle and Gateshead Children and Young People Service, as well as Dr. Aisling Martin, who's consultant clinical psychologist for Trusting Hands Gateshead. And they're going to be presenting for us this morning trauma-informed care for children and young people who are considered high risk, high harm and high vulnerability. They're going to be talking about two newly commissioned trauma-informed services that have been developed in partnership between Cumbria, Northumberland Tyne and Wear NHS Trust, and Newcastle and Gateshead councils. So Aisling, if you could click the next slide for me, please, that would be much appreciated. Perfect. So the Connect and Learn sessions are a series of online learning events planned with the purpose of sharing and spreading improvement work across the North East and North Cumbria health and care system. And each will have, a different focus. But the Connect and Learn sessions are designed to be more than just information sharing. They're also an opportunity to connect with like-minded colleagues around a specific topic. Hopefully to generate some ideas as well as part of that, and looking at ways in which you might be able to take that learning to make improvements in your own work, team or service. Next slide, please, Aisling. Thank you. So before we kick off, just some very quick protocols. If you can keep yourself muted when not speaking, post any questions that you might have in the chat, and we'll also have time for questions at the end. I think Kate and Aisling are hoping this is going to be quite an interactive session anyway, so it'll be great to hear your voices. Listen with respect and be present. Please pass on, share the learning, spread the word about these sessions, and please be aware that we are recording. I will post a link to be able to give feedback in the chat. So if you could complete that, I'd be much appreciated. It's very short, it's only a few questions. I will now pass over to Kate and Aisling.
Thank you very much, Ashley. So I guess before we start today, one of the things that we thought it might be helpful, given that we are quite a small group, is to just do a really quick round of introductions, just to find out who we've got on the call, what your roles are. And I guess if you feel able to say a little bit about what interested you about joining the session today, or what you hope to get out of it, that would be really helpful for us, because then we'll try to, I suppose, alter what we're presenting accordingly. So is that okay with everybody, just to do a quick round of introductions? I'm going to go on my list from the top, and I'm going to hope that I'm not going to miss anybody out. So Kate Allen, could you introduce yourself first?
Yeah, my name's Kate Allen and I am the Deputy Designate for Safeguarding in North Cumbria, part of the ICB. And I suppose just to hear what was kind of going on over on the other side of our ICB, because obviously trauma-informed care is something that's kind of, it's the buzzword at the moment, isn't it? But actually, how does that actually work, and what can we do from a commissioning perspective, kind of support that framework or kind of model, really? So yeah, just to listen and see what's going on, really.
Thanks, Kate. That's really helpful. And I think you're absolutely right, aren't you? Trauma-informed care is a word that's being used a lot at the moment, but actually how we apply that in practice is often the really difficult bit. So yeah, hopefully we'll be able to generate some ideas for you all today. So I've got Jen next, Jen Anderson.
Hi, I'm Jenny Anderson. I'm Senior Case Manager for the Newcastle Gateshead Continuing Healthcare team. So my role is really working with people 17 upwards. And I suppose the reason I came here is because I do a lot of the transition links with the Children with Disabilities team and other teams. And I currently have a 20-year-old who's with the PBS team, and they're talking about the trauma-informed sort of practice and PBS plan that he needs to put in place, where we need to put in place to support him with the stuff he's going on. So it's kind of, it's a little bit of a, I suppose, a new world. It's stuff we hear about, but I've never had a patient where they've been talking about it before. So I thought I'd hop on here, so I kind of had a better clue when I'm working with them.
Thank you very much, Jen. Julie Bailey.
Hiya, I'm Julie Bailey. I'm one of the workforce programme managers in North East North Cumbria ICB. I'm leading on a project called the Universal Family Programme, supporting young people with care experience, so care leavers, into employment, education and training. So interested in learning more about trauma-informed care and trauma-informed approaches and how that might link with that work.
Thanks very much, Julie. That sounds like a great programme. We'll be very interested to connect with you, I think, and understand about what you're doing as well. Nicola.
Hiya, I'm Nicola Childs. I'm the Children's Commissioner within Sunderland ICB at the moment. And I guess I've done a lot of work around the neuro pathways in various patches that I've worked at, and we know that a lot of the children coming through those pathways are actually more trauma, as well as autism, ADHD traits. So I'm very keen on developing those lower level earlier intervention services that actually focus around trauma, and how we can get in there earlier and work as a system really around that trauma informed approach.
Thanks, Nicola. That's really great to hear. I think it's Dinraj. I hope I'm saying that right.
It's Divya. Hi.
Hi, Divya.
It's all right. So I work for the Health Innovation Network in Northeast North Cumbria. I lead on quite a lot of the mental health work that we do, including the trauma-informed community of action, as well as annual physical health checks for patients on the SMI and LD registry. So trauma and being trauma-informed is important throughout all of the work that we do. So that's why I'm here.
Thank you very much. Who have I got next? Louise Hope.
Hi everyone, I'm Louise Hope and I'm currently covering the children's commissioning packages within North Cumbria ICB. My role was just a temporary role and I am actually leaving the organisation at the end of March. However, I still thought it was useful to attend just because obviously it is an area of interest of mine. I am a mental health nurse by background, so I just thought it would still be helpful for personal professional development to still attend.
Absolutely, Louise. Lovely to have you. I've got Lindsay next.
Hi, I'm Lindsay. I'm a staff nurse, but I'm with the health visiting team in Allerdale and Copeland. I'm new to the role, so I don't really have any background of children and young people. So I've just came on to get as much knowledge as I can from anything that'll help me obviously apply in practice.
Lovely. Lovely to have you, Lindsay. Mark.
Hello, my name is Mark Philpott. I'm project manager for Children and Young People's. Oh, you still there?
Yes, yes, we can hear you, Mark.
So, Mark Philpott, project manager for Children and Young People's mental health services in County Durham, Darlington, and Tees Esquire Valley. What I'm really hoping to get from the session today is what I'm doing. One of my work streams is helping to really overhaul the training and development of our paediatric staff. And although we've said about we wanted to get on trauma-informed care, trauma-informed practices, it's really, other than just sending them to some modules or doing it online, it's really how can we actually contextualize this, how we put it into practice and really embed it into our culture so that it's properly being used. That's what I'm hoping to get from today.
Yeah, absolutely, Mark. That's so important. Thank you. Emma.
Hi, I'm Emma Place. I'm the clinical quality nurse lead with the ICB, and whilst children don't currently fall within my remit, when I'm doing things like the leader reviews and SI panel, I think it would be really useful. But aside from that, I'm a foster carer as well, so obviously it's central to the therapeutic work that we do. So when I seen it, I just thought it would be from a professional development point of view, and it will link with some areas of my work as well.
Thank you very much, Emma. Amy.
Hello, I'm Amy Sim. I'm an assistant psychologist in the North Tyneside Community Learning Disability team. I think it's really important for our team to just keep getting updates on what's new, so I can feed that back. But also, my background's in PBS, so we've recently done quite a lot around kind of making PBS plans more trauma informed. So it's really interesting from both perspectives.
Thank you, Amy. And finally, I've got Mary Claire.
Good morning, everybody. I'm Mary Claire Telford. I am the Domestic Abuse Project Lead for Cumberland Council. Previously worked with high-risk young offenders within the youth offending team, particularly those who were convicted of harmful sexualised behaviour. I've worked with Aisling on a couple of cases, so it's lovely to see you again. Thanks for having me today.
Oh, thank you very much, Mary Claire. It's always nice when you see a familiar face on a training like this. It just really helps. So thank you. So obviously we have got a presentation for you today, but we are going to, if we can, just try to generate some discussion, I guess, from you all, because I think when we're working with children and young people who fall under this category, one of the things that we really try to do is to keep lived experience and children and young people's experiences at the centre of everything that we think about and everything that we provide. Obviously, we were really mindful today that it wouldn't particularly be appropriate to talk about the direct experiences that we have of the young people that we're working with for confidentiality reasons. So what we thought we would do is to bring a case experience that has already been reported in the news, and I suppose just get your perspectives on, if you heard this story, what you would be thinking about, what you would be concerned about, what you would think the next steps would need to be. I guess part of that is just thinking about that from your role, from your perspective, from your service. But also, one of the things that we do really recognise as part of the work that we do is that when we hear these stories, that it generates feelings and emotions in us as professionals as well. Sometimes feelings of frustration, anger at services around these young people, maybe feelings of sadness or despair even at the situation that they're facing and where they've ended up. If you feel okay to share some of those feelings with us, please do that, and it's fine also if you don't. Also, we always offer, when we talk about these sorts of young people and these sorts of situations, the opportunity for people to speak to us after the training, if that's something that would be important to you or needed, I suppose, within your role. So today we wanted to talk about, they've called her Claire in the news. Obviously, they have anonymised that situation as well, even by reporting it in the news. But this is a young person who, remind me, Aisling, where she was in the country?
She was in, I can't remember, but I have shared it. So
not in our
Lancashire.
Yeah. Lancashire, yes.
Lancashire.
I knew she was somewhere in the northern half, but not quite as far up as here.
So this is a young person who, and it's reported in the news because it went to court. So it went in front of a family judge. And at the point of going to court, this young person was presenting with lots of difficulties and lots of concerns. And what the judge ordered for her as a 15-year-old is that she would be subject to a deprivation of liberty order and she would be cared for. Well, cared for is maybe not the best term to use, but she would be supervised, I suppose, by 4 members of staff in an acute hospital setting. So just in hearing that information as a group of professionals sat around today, what would be your immediate thoughts about that situation for that individual? What would be your concerns? What would you be thinking about from your agency perspective about what the next steps would need to be for Claire? Again, this is just an open conversation just to generate discussion and ideas. There's often, we very much recognise that in this type of situation there is no right answer, but it's just would be interesting for us to hear from your different perspectives and your roles and where you sit, what sort of ideas or thoughts that would generate in you. Does anyone have the courage to put their hands up and go first? Oh, lovely. I'm going to go in order. So we've got Mark first.
Well, my first thing would be, who's actually been consulted on this decision? Is it just something that's coming straight from the courts? Is it the local authority as well? Is it the hospital and the clinical staff? And really, I suppose the big question here is that the right place for quote unquote Claire? Is that really what's right for her? And if not, where should she actually be, and who should she be? Who should it be discussed with?
Yeah, thank you, Mark. So lots of thoughts there. How have we come to this decision as a group of professionals around Claire? How have we generated conversations across agencies about what is best for Claire in this situation? And is that the right thing? Is that the right thing for a vulnerable 15-year-old to be cared for in an acute hospital setting? Thank you very much. Jennifer? Do you want to go next?
There's somebody else before me, I think.
Was it Nicola next?
Yeah.
Sorry.
It's all right. I'm not precious. It would have been all right. But for me, it's always the level of staffing, and I know it's the risks, and I totally accept all that. But for a 15-year-old girl in an acute setting to then have 5 members of staff, I mean, how would you ever come back from that? Where's her norm?
Yeah, absolutely. I suppose, if we think about just ourselves and how we function, and how, again, with hybrid working that we now do, that, we like time when we're amongst other people, but we also want time when we're able to be by ourselves. And essentially we've got a vulnerable 15-year-old who is being supervised 24 hours a day by 4 adults. It's quite highly likely as well that those adults will be changing frequently, so they won't be consistent members of staff. It'll be different people who are coming on shift every day. And if we think about, from a personal perspective, how we would feel and how we would manage that, then it's even more difficult to think about that for a 15-year-old.
And if she's got I mean, we don't know her case yet, but if she's got attachment issues or anything underlying, and we've got a constant carousel of staff coming in and out who are all going to be so different, and it's intimidating for any child or any adult. I couldn't have 4 people watching me all the time. It's just, I always think these staff ratios are crazy, although I understand the logic behind it, but there's got to be another way. I just think.
Yeah, absolutely. Thanks, Nicola. Kate?
Sorry, I couldn't find my mic button. It's quite interesting because I actually cited this case over Christmas for something that was
great minds think alike.
Yeah, it was occurring, not this case, but I mean, and I think it typifies for me a broken system where we're trying to kind of medicalize children into fitting into a system that's already broken, and we're not doing the right thing by them, because I can't get my head around, irrespective of risk or whatever, for staff members, and actually how traumatic that would be. And I feel like, irrespective of how she's got to where she was, I kind of have a bit of an awareness, but I can't ever see how that was the right thing. And I think, interestingly, because obviously they've used the dolls framework there because of her age, but actually this is occurring with children under that don't have that legal redress, or that, that legal framework around them. And then you are stuck with, actually, how can we get the right care for the child when, there's no placements, or, and it just feels like the children are kind of the last thing that we're thinking about, in terms of this system that just doesn't work. But yeah, that's just my thoughts.
Thank you very much. And I think so many of the points that you've made there are so relevant, Jennifer. I think, and you use the word, it's further traumatizing. One of the things that we really think about in trauma-informed care, and there are 4 R's of trauma-informed care, and the last R is to resist re-traumatization. It is to resist, because in some circumstances we will act in a way which is re-traumatizing for young people and individuals, but we need to resist that, and we need to think about what steps are we taking as professionals, and what further impact is this having on this young person, and also, you know, how do they move on from that? And I think you're absolutely right when you're talking about, you know, the challenges of I suppose a broken system and where we're at, and I guess one of the reasons why we're talking about this case today and deprivation of liberty orders is because that is also being recognised at a national level as a significant problem at the moment. So there is a piece of work that's happening between the Department for Education and NHS England, being led by Anne O'Haley, to look at they're calling it children and young people in complex situations, which again is an interesting use of language, because I think there's a recognition that they're in a complex situation because often of the decisions that have been made by professionals around them, they often don't have a voice in that, as you've articulated, Jennifer. And I think there's been some work done by the Nuffield Foundation to really highlight the lack of the child's voice in the centre of some of these decisions, and some recommendations will be coming out nationally about how we address that as systems around young people. Who have I got next? I think Jennifer, have you? Well, it's saying that you've still got your hand up, but I can also.
I think it got a bit confused in the order of things. I was the only thing I was going to add in, was just, you know, what does the person they're calling Claire want? I had a quick flick through the thing. It said her mother's died. She's got no formal diagnosis of mental health. What does she want? Do you know? Has anybody ever? Can she vocalise? Has she got an advocate? Is anybody helping her to say that? Because I think when you're in a little bit of information about me, I have a daughter who was been involved with CAMS briefly, and it was for a small, not in the scale of Claire, it was for a small thing and nothing, but I found the system horrific. Right, there were lovely workers, they were dead supportive, but as a mum with a child who was 12 having a tough time, I found it difficult. So how is Claire going to navigate that system of people telling her what to do, what to think, where to go, how to behave? Who's helping her, who's supporting her is kind of where I came from as a mum, but also as a professional. Like, there's no mention of what she wants in the little write, when there probably isn't. There probably is more documentation, but that was just where my little mind went.
Thank you very much, and thank you for sharing that, because I think it is really important we do try to encourage, I guess, you know, everyone who works with children and young people to recognise that not only is it really difficult to hear about the stories of these young people, but also that it potentially touches on our own experiences as well. You know, that's very much the case for me. Also, I've had my 2 boys access services as a result of some of the experiences that we've had as a family. And I'm a professional who works in services, and it was still very, very difficult to think about how we as a family access support in a timely way and in a coordinated way, and some of the responses of the system and professionals within that were difficult at times, and I think it's really important that we try to encourage people to be able to talk openly and honestly about their experiences and learn from that. But as you say, for a 15-year-old in that system who has potentially no one around them to advocate for them in that situation, that's really difficult to think about.
I suppose my background, I used to work with homeless teenagers, and I think a lot of them had been in care for various reasons, and at that sort of 15, 16-year-old age, your default setting is to have people F off, you know. And I think professionals sometimes love to hear that, because that's their golden ticket to, oh well, they wouldn't engage. And, you know, sometimes you need to say, well, it's F off, please, let's carry on with the conversation, instead of, oh, how dare you swear. And I think that always sticks with me, is we have different languages and different sort of ways of communicating, and I don't know. Anyway, I'll rattle my cage somewhere else.
No, I think that's so important, because I think, you know, it's about working out, isn't it, what the young person's trying to communicate. And ultimately, if you've been a young person who's experienced repeated loss and repeated sort of individuals around you who've not been there consistently, who you felt continuously let down by, then probably your default position is going to be go away, with the swear word thrown in or not, because you're not going to trust that people around you are there to have your best interests at heart and to keep you safe. But we need to understand that. We need to recognise that that's a form of communication, and that's really relevant to that young person's experience.
And Kate, I just sorry, I was just
carry on. Actually,
sorry,
yeah.
I'm just leaping in. Just you made a really important point there as well, Jen, where you and what Kate had said there about the work that's been done talking about children and young people in complex situations. So what you said there is that they're often seen as they won't engage in services, and actually what we know is that often the experiences that these young people have had have led to them being very mistrusting of adults, very mistrusting of professionals and systems, and that, you know, they won't engage with services very much locates the difficulty as being in the child, and so moving into that position again, language is really important in how we describe what's happening. So children who are in complex situations brings together all of those things that you're talking about and the responsibilities of other people, and it's just that we haven't found a way to connect with that young person yet.
Yeah, I agree with that.
Thanks, Ashlyn. Kate, I get people's names right this time.
It was just to add to that, I think sometimes as a system, professionals, whatever you want to think, we hold children to a higher accountability in terms of their behaviours, because, you know what, I've wanted to say to people, go away, you know what I mean? So it's like, why can't a child do that as well? They're still learning how to, you know what I mean, to find them behaviours to get their needs met, isn't it? And, you know, and I just think we do set the bar way too high for the tolerance of that, and we just need to be a bit more understanding, don't we?
Absolutely, Kate, and they're still developing, aren't they? And if we throw in the fact that, you know, it's a vulnerable 15-year-old who has experienced probably a significant amount of trauma in their life, which has impacted on their development, and then we throw in the pandemic as well, which we know has impacted massively on all children and young people's development, then, you know, essentially we're expecting this 15-year-old to be a mini adult. And as you say, sometimes we don't always regulate our emotions perfectly every day. So yeah, the expectation is very high on these young people. Emma?
Yeah, thanks. And just sitting and listening to people agree wholeheartedly. I think there's something to be said as well for quite often, and I'm thinking of it from a few different angles, but quite often they're described by their labels, or their story is told by their labels and by their reactions and outcomes, as opposed to their true story and the thought behind how those actions come about. So when they're being presented from a professional communication relay, what overshadows that is use of aggressive behaviour, can be compulsive in this, can give outbursts in that, rather than stripping it right back and going, this is Claire, this is the start she had, this is how, to get a bit of understanding as to why she may be like how she is. I hope that makes sense. It's probably made more sense in my mind than it has out loud.
It absolutely makes sense, and you've just beautifully articulated, I think, one of the central principles of the service that we've set up. So it yeah, it absolutely does make sense on every level. Is there anyone else who wants to come in and contribute with their thoughts around Claire? And if not, we'll move on to talk a little bit, I suppose, about our local solution to some of those challenges. Is there anyone else that wanted to come in? Obviously, we'll have another opportunity for questions in a little while. I just wanted to make sure we've heard everybody who wanted to contribute. I'll wait a moment. Right, over to you, Aisling. I think.
Just let me work out my technology first. Okay, have I shared my screen is the first question. Great. Yes. So it was so lovely to hear all of those points that people were making, and they fit beautifully into, it was a lovely segue into what we're going to talk about next. So what we've been talking about there is really how much disintegration there is in the system around children and young people who have, find themselves in these complex situations. And what we know is that the natural resting state of systems is a place of disintegration, and we actually have to work really hard to come together to find that sort of shared understanding. We know that different agencies and different organisations all have different remits and different aims, and at times some of those aims can actually be counterintuitive to go alongside those of other agencies. And what that ends up looking like is this is just blatantly stolen from our colleagues in NHS England when they use it to describe the framework for integrated care. But this cartoon is the blind men and the elephant. And what it shows us is if we're all looking at different bits of the picture, and if we're all only understanding the bit of the picture that is in front of us, we're never going to understand the full thing in front of us. So what we want to do is, when we're thinking about integrated care, is think about how do we work together for whole systems to be sharing information, working collaboratively, and really understanding the story of that young person, so we know how best to work with them and to meet their needs. So that's where the framework for integrated care comes from. So this is the framework that our services have been set up under, and to meet some of the principles within this. So what it does is it gives us a set of guiding principles and practices that act as a template. So there are vanguards across the country. We're one of the vanguard sites on part of this 2-year pilot, and they haven't told us exactly what it is that we're to do, but we have a set of principles that we are to follow that aim to bring those whole system approaches together. It goes along with that idea of trauma-informed care, where we're shifting away from that what's wrong with you to think about what's happened to you. So the point that somebody made a minute ago about understanding the story really is integral to everything that we're doing. And the point that in Claire's story, actually, we don't know what's happened in her background, so how can we know what's going on for her at the minute when we can't see that behaviour in the context of her experiences? So the community framework was based on Secure Stairs, which was set up about 5 years ago in the Children and Young People Secure Estate. And the idea of that was to build a formulation informed, so based on understanding the story, whole systems approach that really recognised the young person's story, how that influenced their current presentation, and also sought to prevent re-traumatising children and young people in the systems that we have set up. So we used Claire as an example, but when the term high risk, high harm, high vulnerability needs is a cohort of young people who have multiple persistent and severe needs. So their multiple needs, we might see difficulties across education, in their home or care setting, in terms of mental health needs. And historically what's happened is those needs have all been met in silos. So you would go to CAMHS for your mental health needs, you would go to social care for your social welfare needs. And things happened in parallel, so the child found themselves often either having to present with multiple services, tell their story multiple times, and actually those systems not working together. So we know that when there are lots of services involved, that actually it can feel really overwhelming to young people and to families. And we know that this is a group of young people who will have needs across those domains. They're persistent needs, so we know this isn't just an acute phase, it's something that we're seeing over a longer period of time. And they're severe in that they don't respond to the traditional interventions or services in the way that they are traditionally set up. And the other common factor that this cohort have in common is that it's often framed by family and social context. So it's very much about the lived experience that they have had during their early years and that early upbringing. So the principles that we are following, there are 6 of them. We've touched on some of them already in the conversations that we've had, which is lovely to hear. So every interaction matters. So this is about how important it is to think about, regardless of who is working with the child, every interaction has the possibility to be helpful or harmful. So that means whether it's a teacher or a teaching assistant or a social worker or the receptionist in your CAMHS service, that every experience that a child has, given that they have developed this pattern of mistrust in others, has the opportunity to start to shift their ideas about how other people might respond to them. We know that young people and the relationships they have are at the centre of everything, and that that we need to think about genuine co-production. So how do we hear young people's voices? How do we hear what they need from services and what they want from services, and how they want people to respond to them? And we know that those spending the most time with young people, which tends to be their carers predominantly, followed by education staff, they're the people who are primary facilitators of change, and they're also the people who will influence the young person the most. So the fourth principle is that positively influencing that day-to-day care is really our primary intervention. And we spend a lot of our time working with carers. So I think it was Jennifer, when you were talking about experiences as a parent and how difficult that is with working within the systems, we know that and we recognise that, and a lot of our interventions are targeted towards supporting those primary caregivers to understand and to care for the child. Possibly the most important, number 5, is all behaviour is understandable in context. So everything that we do is based on that understanding of the story, developing a shared understanding of that young person's needs and behaviours based on what we know has happened to them and what we know that their experiences have been. And if we can do that in a way that involves all of those people within the system so that we can all see the overall picture, then we're much more likely to be able to meet those needs in a helpful way. And the 6th one is moving towards thinking about those people around the young person and the system around the young person. And there's a commitment to build and sustain trauma-informed organisations, which we'll touch upon shortly. There's lots of outcomes that we hope the framework is going to show us. I would put the caveat that we're in a 2-year pilot, and I think a lot of these things are likely to be longer term outcomes that we will see. But they're across those different domains that we know that young people experience difficulties with. So young people's well-being, we hope, will improve over time as we can have services working together and understanding how to sequence interventions to meet their needs. We hope to increase the likelihood of those people who need mental health support accessing that support in a timely way. We'd hope to see reduction in high-risk behaviours, again, understanding what the function is of those behaviours, understanding what young people are communicating through those behaviours means that professionals working with them can seek to target those behaviours and to provide interventions that are supportive to them. Reducing mental health concerns, which again goes alongside that improved wellbeing. Developing organisations that are better trauma informed. So this is very much about how do we increase the awareness of trauma, both on the individual, but also on the people around them, on professionals who are working with that young person, professionals who are supporting those working with that young person, and how do we increase the experiences of safety in the systems around the young person, because we know that trauma spreads and there's a ripple effect throughout those people around the young person and throughout the system, so systems can also become traumatised. We're hoping to see improved purpose and occupation. So again, if we're working together closely with colleagues in education, everyone understands the young person's needs, we're much more likely to be able to develop a programme of work that really connects with them and allows them to engage with that. And improve stability of home. So this is really about supporting predominantly care placements or maintaining placements for children who are on the edge of care, to think about the child's context as a whole and think about what supports can be offered by the system. It broadly fits in with people I'm sure will have seen or know about the Thrive model, and our approach sort of goes through the getting advice, getting help, getting more help through our direct work with the system. And the risk support is when we provide support around risk management strategically in the local authorities, or also our liaisons with other colleagues across other services. So in terms of what it looks like locally, so we have 2 services. We have Trust in Hands Gateshead and we have Future Focus Newcastle, which work respectively into the 2 local authorities. So this was developed in partnership between the local authorities and Cumbria, Northumberland, Tyne and Wear NHS Foundation Trust. We are teams of mental health professionals, multidisciplinary teams, and we're embedded into the local authorities. So we have connections across children in care, youth justice, contextual safeguarding, and residential care, because that is broadly where these young people who we see as high risk, high harm and high vulnerability tend to be connected. our key interventions are very much around the system. So we don't do any direct work with the young person, which I think initially was something that people found very difficult to understand, why as a team of mental health practitioners working into social care, we wouldn't provide that support to do so. But actually what we know is from the principles of the framework for mitigated care, the best results we are going to have are by influencing those people who spend the most time with the young person. So one of our colleagues in NHS England, Andy Rogers, often refers to the rule of 167. So there's 168 hours in the week. Who's going to provide more of an influence and a support to the child? The people who spend the 167 hours, or the expert who comes in for 1 hour a week for an appointment? And we know it's the people who spend the most time with the young person. So our interventions are broadly around their consultation based. So this is about getting together those people who are working with the young people to consider what the concerns are in the system, and also to consider the young person's risks, needs, vulnerabilities. A lot of emphasis is put on understanding the story. So as I mentioned before, having that collaborative approach so that everybody understands the behaviour that we're seeing in context. And what we know is that also shifts people's attributions of behaviour, so actually can have an influence and an impact on how we then respond to that young person. Thinking about the professionals working around the young person, we are hoping to introduce a graduated training programme so that everyone understands those key concepts around child development, attachment, what is trauma-informed care, what does that mean, and how do we put it into practice. And offering to the staff team scaffolding, supervision and reflective practice, because again, we know that the systems can become traumatised by this, and if we can reduce the stress and anxiety within the system, we're much more likely to get a less reactive response, because that's what often happens in crisis, is you see the number of systems involved, the number of agencies involved goes up, and actually people don't know who's supposed to be doing what, so it leads to sort of a position of chaos. As I mentioned, we also contribute to care and risk planning. We liaise with multi-agency partners. So again, it's about trying to pull all of the different pieces of the puzzle together for that young person so that we can have that collaborative approach. And we work sort of strategically and organise across the organisation as well. So I'm just going to briefly hand back to Kate to describe this one.
I guess one of the things that we wanted to do, just to try to sort of bring it alive for everybody, and this is a young person who I won't share their story because the details of that are confidential and you know wouldn't be appropriate to share, but it is a young person who I have shared nationally at one of the shared learning events with her consent. But essentially this is a young person in Gateshead who was subject to a deprivation of liberty order, and the reason for that is because, and one of the, I suppose, misconceptions that often happens in the system is that these situations arise because there are not enough secure beds, secure welfare beds, in order to, I suppose, manage these risks from a secure position. And this young person did have a period of security. So she was in a secure welfare bed in Scotland for 9 months. She came out to a residential home in Gateshead, and the risks remained exactly the same as when she'd gone in. And I think it's important for us as a system to recognise and understand that just putting increased security around young people does not always address the issues in the way that we would hope. And these are the levels of missing episodes. And when I say missing episodes, they were high risk missing episodes. I mean, they've been articulated as medium risk, but that's mainly because this young person would frequently go missing and say that she had a plan to end her life, but that she didn't often come to harm on those times that she went missing, so that's why it's classified as medium risk. But if we look there at the level of missing episodes when she came out of the secure welfare placement into residential care and how that's dropped over time, that is as a direct result of the Trusting Hands team and the work that they've done and the understanding for the whole system around that young person, because this was a collaboration between police, who were frequently in contact with her, my service, so Children and Young People Services, crisis teams, street triage, residential care staff and the local authority. And it's only by having a really good understanding of her experience leading up to this point that we've been able to get those outcomes. The other thing to highlight is that this is a young person who was out of education completely and is now in mainstream college. And so in respect of the significance of that for her life moving forwards, I think it's just really important to recognise and understand that with the right type of, I'm going to use the word intervention, but essentially it's an understanding across professionals about the needs of these young people. We can get really good outcomes for them. Back to you, Aisling.
I guess that case is another example of the different systems that we interface with. Again, thinking about high risk presentations, there are often other services involved with young people in terms of either their presentation or their risk of harm to themselves or their vulnerability from others. So we attempt to, as well as those sort of core services of CAMS or SIPs and the local authority and education, we also try to ensure that we interface with those other services that are likely to be involved when children are within that kind of category. Just, I suppose, is there any questions about, we do have space for questions at the end, but I suppose about our services specifically before we move on to think about kind of organisational trauma? No, people happy to wait to the end. So as I mentioned, sorry, Jennifer.
Sorry.
Come on
Sorry,
in.
I might be gone by the end because I've got a meeting at 10:30. I just wondered, how do you link in with the service?
So when we have either consultations or understanding the story, we ask for those to be multi-agency. So we will often hold the meetings in education to allow for education staff to come. And if the child has a named worker in those other services, we'll invite them to come as part of that so that all of the contributions are shared together in that space. If we have a consultation, but we know that someone is open to SIPs, it might just be as simple as we have a conversation with the person who's working with them to ensure that we know what their plan is, so that we're just not working at odds with each other. We have had some experiences where we have gone through a whole pathway of work, and as a sort of door handle comment at the end, someone says, oh well, I'm actually going to have a consultation with Forensic CAMS next week. And you know, when we know that, it also saves the system and saves those professionals, so usually social workers, it saves them going back in and having a repetition of the same conversation. So what we're trying to do is work closely with those colleagues to make sure that we are working collaboratively, so that as systems we are not adding an additional stress to people and expecting them to come to multiple meetings about the same young person if possible. It's still a work in progress though. We haven't perfected it yet.
And I think, yeah, I think the important thing to highlight is that one of the things that we were really keen not to do is to create another referral system. So it's, you know, the involvement of Trusting Hands and Future Focus doesn't happen on a referral basis. And what I mean by that is that, you know, these young people don't have to meet a specific criteria, other than, you know, being involved in those teams that we've highlighted already, and professionals don't have to fill in a form. One of the things that happens in a very embedded way, particularly in Trusting Hands, is what we would call connected conversations. So really, they are there, they are embedded in the council, they have all of those teams around them, and if a professional is worried and wants to seek some advice, they will just come and have a conversation with the team. And that's to very much recognise that often we make decisions from a position of worry, of concern, of fear, and that we need to recognise that that's what happens within the system, and we need to provide containment to the system to allow them time to think, to reflect, to not have to necessarily respond immediately in the moment, but to take a step back, to feel contained by that conversation, and then to make the right decisions moving forwards.
Okay. And I think the other thing is just to note is that we're employed by CNTW, which is the Mental Health Trust, but we work into Newcastle or Gateshead, but we still have access to the notes for young people on a regional basis, which can be really helpful in terms of where there's a certain narrative around what is or isn't happening for a young person, which is often driven, as Kate was saying, by the anxiety within the system. Actually, we can look and see what's happening, and that can inform our decisions as to what our input might be as well. But that, I suppose, leads quite nicely on to trauma-informed organisations. What we know is that in organisations such as the ones that we all work across, and children's social care particularly, we are all influenced by the trauma of the people that we work with on a day-to-day basis. And this is just a lovely quote that I often put into trauma-informed training: is the expectation that we can be immersed in suffering and loss daily and not be touched by it is as unrealistic as expecting to be able to walk through water and not get wet. We all get touched by trauma when we work with trauma, and a huge part of the framework is supporting those systems to make decisions from a trauma responsive way rather than a trauma organised way. And what that means is that the system, if the system responds in a trauma organised way, they're responding on behalf of their own trauma experiences. We're responding faced with our own anxieties and our own anxieties about what it is or isn't happening for that young person. Trauma responsive is where we recognise and we respond to the trauma that we are seeing from the young person, from the young person's story. But a lot of emphasis is put on how do we support the organisation. Again, some of this is a work in progress, and I mentioned it when I talked about what our interventions are. We are embedding reflective practice for our teams at the moment, and we're influencing strategically across the services to try and embed trauma-informed language, trauma-informed practice into all aspects of the organisation. That's a big task, and we're not going to be solely responsible or able to manage that across all of the organisations that we're working with, but we're hoping to start with those teams that we're connected with to ensure that we develop a base level of understanding across those teams, that those teams feel very supported, and that we help them through that embedded way of working to slowly make changes to the language that they use, the questions that they ask, and their own responses to the trauma that they're working with. And I think that is everything that we wanted to say today. I'll just pop up, we've got our contact details there. I'm sure, do these slides get shared, Ashley, with people?
Yeah, we can share them out, that's not a problem.
So the slides will be there. I'll just stop sharing this for a minute. I know the feedback forms on the next one, but just, does anybody have any questions or reflections that they want to make about what we've covered today? Jennifer?
Because I just think it's really interesting, and I really hope it works, because I think it will make a huge difference to the young people we work with, but it'll make a difference to us as well, because I think, you know, the one thing that we're really good at forgetting is ourselves, and just the fact that we can access that support and that kind of understanding of what we might pick up from working with people. You know, we're the worst in the world. Like, you know, we're fine, I'm fine. You know, I hear it all the time, and then you go home and you think, where's the wine? So
yeah,
you know,
and we know that, and actually, it's lovely to hear people recognizing that, and that's one of the things that we are slowly helping the system to recognize the importance of that. You know, you can't pour from an empty cup. You put your own gas mask on first. Whatever, you know, whatever analogy you want to use, we can only do what we can do with the resources that we have at the time. So we have to protect those resources, and particularly social care where we work, you know, they are a finite resource. Social workers are on their knees, so the more we can do to bolster and to provide resilience within that system, the better it's going to be for young people who use the system.
Definitely. Yeah,
thank you for that. Mark?
Yeah, hi. Just for my own clarity, can you give an example of like a difference between trauma, what's the word you said, the trauma-informed organisation and the trauma-informed response, just so I know the difference between the two?
So trauma responsive is where we recognise the impact of the young person's experience and we recognise their behaviour as being a trauma response or an attachment response, and so we can step back from that and respond in a kind of open and engaged and a more thoughtful way. Trauma organised is where the presentation that the young person is bringing sets off our own kind of defence responses or our own anxieties, and actually we respond based on those as opposed to thinking about what they're seeing. Does that make sense? So
I suppose, yeah, Mark, if we think back to the case study of Claire, you know, essentially the response of the system, as everybody actually beautifully highlighted through the discussion, was a trauma organised response. So it was about what we must do in this situation is to prevent further harm by ensuring that she's, you know, has 4 staff around her at all times. That's a trauma organised response, because it's about saying, you know, essentially we just need to stop any harm coming to her, and so therefore that's the only way to do it. But actually, very much through the conversation that we had, what we got to is a much more trauma responsive position, which is, let's think about actually the impact that would have on Claire, how that would make her feel, you know, whether that would help her to move on and help her to make progress and to recover. Is that the case? No, we don't think it is. So if we recognise that and we are responsive and understanding about her story and the impact that our decisions are going to have on her, what are we going to do differently, and what are we going to try to achieve in order to get Claire a better experience? So in a way, the case study represents exactly that.
That makes sense, Mark.
It really does. So thank you for clarifying. I thought it was something on those lines, but I thought I'd just ask in case I'd gotten the wrong end of the stick. I suppose, like, really for me, it's like looking at like because at the moment one of the bits of work I'm doing is like we're trying to get a ligature light room put into like the pediatric wards. But for me, the bigger picture is, yes, we take away all of their things so they can't hurt themselves, just like what you said before in the with the secure unit. That doesn't really get to the main problem, because they'll find a way potentially, even if everything is reduced as much as it can be. But even when they leave, they're still at that risk. It's like, really, how can we react so we actually get to the heart of the problem? And that's where that's why I'm struggling with.
Yeah, and I guess that's where we would go to understanding the story. So if we can understand the function and what the behaviour is communicating and how that is set in the context of what that young person has experienced, then we can behave in a trauma responsive way. Whereas what you just described, the taking everything away, removing everything, that's about our anxieties as a system. We don't want anything to go wrong. We want to make sure that we've covered all of our bases. That's when we're being trauma organised, and that's about the impact that it's having on professionals in the system.
So like, sorry, just, is it you're part of, is it Helping Hands that you're a member of?
Trusting Hands, yeah.
Trusting Hands, sorry, yes. Okay.
Yeah, it's all right. We got called Helping Hands quite a lot. I quite like it. But...
It sounds a bit nicer, to be fair. But yeah. Okay, what was the other one you mentioned? Future
Focus. That's the Newcastle team.
That's the Newcastle. Okay. All right. Yeah. Thank you so much.
No problem. Nicola?
This is like a really practical question from a commissioner now. Is the Trusting Hands team jointly funded or health funded?
It's got a long and complex commissioning history.
Okay.
So initially we set up services purely for residential care. So that was joint funded at that point, and it was very, very much 50-50 health and social care. The additional funding for the pilots came from short-term NHS funding, so that's currently wholly NHS funded. But one of the things that we are going to try to do moving forward, so we're working with the Applied Research Collaboration, are going to do some work for us around cost effectiveness, because we know that that's really important.
Yeah.
Essentially, one of the things that we recognise is that, you know, whenever we provide interventions like this, what essentially we're trying to do is to recognise that these young people not only have long-term poor outcomes, but because of the way that we respond, that tends to provide escalated financial costs for the system. So for social care, that's around the cost of placements. For health services, that's about the frequency of health responses, potentially the risk of inpatient admission. So what we're trying to do is to be able to demonstrate through the research that this will be cost effective, this way of working, and that hopefully that should lead. And very much from a national perspective, they are talking about joint funding arrangements. They are also talking helpfully about some of the barriers and challenges to joint funding services, because I'm sure you'll know as a commissioner, that's just really difficult to achieve.
Yes.
So
it's up there with world peace, I feel.
Absolutely, absolutely. And yeah, so I think very much the organisations that we're working with, you know, the council and our mental health trust recognise that there are, I suppose, equitable benefits for both systems, but we need to try to articulate that through the research as well in an ideal world.
Yes, thank you.
Thanks.
And Emma.
Thanks. And I might have missed this, so sorry if I have. You mentioned earlier about the workforce education element to it, and I just wonder if, and I'm thinking of specific organisations, independent, local authority, and NHS and education, you know, police, independent care providers such as fostering agencies. Is this something that can be proactively obtained by them, and if so, how, or do they need to be involved with somebody already known and needed within the
I suppose the short answer is not yet, but it's absolutely on our radar. Because we're in this pilot phase and we're not sure what's going to happen in terms of sustainability, so we need to find those questions need to be answered first. But we're sort of starting with the teams that we are connected with to ensure that, so our children in care, residential, youth justice and contextual safeguarding colleagues, that they all have this training so that they understand. We are linking in with, so we had colleagues yesterday who presented a Gateshead children's services across education and social care around trauma-informed care. So we are doing snippets into those, but we are in the process in Gateshead of developing a steering group, which is to think about how do we work across both children's social care, education, and pull in sort of voluntary sector organisations and other people in the sort of wider organisational context to think about how we can be having the same messages. Again, it won't come back to necessarily our teams being the people that do the delivery of those, but we will certainly be happy to be involved in kind of collaboratively developing and making sure that we're all given the same messages across wherever that training happens. And we are still looking for an in with the police, so if anyone has anyone who can link us in that direction, we would be more than happy to think about how we can support our colleagues in the forces.
Right, okay, well on that note, absolutely, we'll take your emails and see if I can help with that.
Thank you.
Okay, thank you.
Fab. Thank you so much, Kate and Aisling. And I always like it when, you know, there's little connections that get made during these sessions, which is fantastic. I'm conscious we've run over. So thank you so much, everybody, for attending today's session. Thank you so much for your participation as well. It really does make a difference to how these sessions go. I've popped a link to the feedback in the chat. So if you're able to fill that in, that'd be much appreciated. And we'll also get the slides sent out to you. We did record today's session, so if you've got any colleagues that weren't able to attend, keep an eye on the website because the link will become available on there probably within the next week. Lovely. Thank you ever so much. And thanks again, Kate and Aisling.
Thanks,
Brilliant.
everyone.
Thank you.
Thanks very much.
Thank you.
That was really good. Thank you.
Thanks.
Bye.
Bye-bye.